My name is Vienna Lynn Brown.
I'm Erin Green.
And I am Annie Landry.
All right, the case of Dominic. A 28-year-old man named Dominic Harrison comes to therapy at the behest of his wife. She notes that he has been acting erratically and insists that he come to therapy after spending their emergency fund on a trip to Los Angeles. Dominic claims that there is nothing wrong with him, believing that he is destined to be a famous director despite having no prior directing experience. He admits to having issues sleeping in the week before his trip, claiming that he simply had too much energy to go to bed. He claims that this is due to his creative genius. His wife reports that he had been speaking rapidly during this time and that his train of thought was hard to follow at times. Dominic reported no drug use during this time other than his prescription antidepressants that his doctor had prescribed the month prior, which was the selective serotonin reuptake inhibitor, Zoloft. He takes a dose of 100 milligrams daily, having initially started at 50 milligrams and increasing his dose after 2 weeks of minimal effect. He had been placed on this medication following a depressive episode that had left him suicidal. Dominic has a history of such episodes. He can recall having an episode in his late adolescence, around age 17, that led to him almost failing to graduate on time. He recalled being unable to enjoy his usual hobbies and feeling so unmotivated that he could often not get out of bed in the morning. He gained a large amount of weight during this period as he coped by eating junk food. He slept for hours each day, and on the rare occasions where he did attend his classes, he was unable to concentrate and often napped at his desk. He was able to overcome this episode and graduate with an acceptable GPA. His latest episode was similar, leading to him being fired from his last job due to non-attendance. So Dominic's symptoms are on par with that of bipolar 1. He has a history of depressive episodes. He shows the symptoms of depressed mood, markedly diminished pleasure, significant weight gain, hypersomnia, which means excessive sleeping, fatigue, diminished ability to concentrate, suicidal ideation, and his symptoms lasted 2+ weeks each time. This last episode that led him to therapy is a manic episode, according to the following criteria. He experienced an elevated mood, an inflated sense of self-esteem, such as when he called himself a creative genius, a decreased need for sleep. He was more talkative than usual. There was a flight of ideas. He had a high involvement in activities that have high potential for negative consequences, such as going to Los Angeles on a whim and spending his emergency fund. This caused severe impairment in social functioning as it strained his relationship with his wife. This lasted a week or more and was not due to drug usage. This points to bipolar 1 specifically because of the severity of the symptoms and the way that it was life altering. And also, just to clarify in terms of the length, for bipolar 1, you have to have the symptoms for at least a week or more. For bipolar 2, you have to have hypomanic symptoms, which tend to be less severe, for at least 4 days.
And here's our letter of referral from a fake licensed professional counselor, Miss Shannon Thompson, written to Dr. Benjamin Clark. Dear Dr. Clark, my name is Shannon Thompson, and I'm currently working with Mr. Dominic Harrison weekly as his therapist. Enclosed is Mr. Harrison's signed release granting me permission to share and discuss his information with you. Mr. Harrison has participated in 4 sessions with me in the past month. I suggested to Mr. Harrison that he schedule an appointment with you to evaluate his current behaviors and symptoms. Mr. Harrison has been experiencing impulsive thoughts, with his most recent incident involving spending him and his wife's emergency fund on a trip to Los Angeles to pursue a career in directing. Mr. Clark does not report of any experience in directing or closely related fields. His wife suggested he enroll in therapy as a result. Mr. Harrison does have a history of mental illness with suicidal ideations. He is currently prescribed Zoloft 100 milligrams due to experiencing depressive episodes in his past. His symptoms include lack of sleep due to increased energy, rapid speech, lack of motivation, binge eating and weight gain, and lack of concentration. My working diagnosis is currently bipolar disorder. Following your assessment, I kindly ask that you share your evaluation with me. If there is a change in medication, please notify me and provide a list of changes and dosages. I hope to hear from you soon as to provide Mr. Harrison with further assistance with his current symptoms.
So there are a few different medications that can be used to treat bipolar disorder. A lot of people know that mood stabilizers are the primary type of medication. Mood stabilizers in themselves are not really an actual category. The following types of medications fall under the category of mood stabilizer: antipsychotics, lithium, and anticonvulsants. So here we have a chart showing a couple of different of the antipsychotics approved to treat bipolar disorder. We have Haldol or Serenus, which the generic name is haloperidol, with the dosage being 1 to 10 milligram daily. We have Zyprexa, also known as Zentiva, and the generic name for that is olanzapine, and the dosages range from 2.5 milligrams to 20 milligrams daily. We also have a medication that is known by a couple of different names. This one is actually one of the more popular ones: Atralac, Bequil, Seroquel, Sondate, and Zolorin. The generic name is quetiapine, and the dosages range from 25 milligram daily to 600 milligram daily. And the next medication is Risperidone, and the generic name for that is Risperidone, which goes from 1/4 milligram to 6 milligram daily for the dosage. Antipsychotics are generally used to treat anything with psychotic features, but they also do have other uses, and as well as treating the potential psychotic symptoms of a manic episode that you'd find in bipolar 1, it also helps stabilize the mood of the individual. So there are some other medications approved to treat bipolar disorder. As I mentioned, lithium is often the go-to. It is considered the gold standard, although some people are concerned about the side effects. Some people believe that it has a little bit more intense side effects than some of the other medications. But its trade names are as follows: Priadel, Camcolit, Lisconum, and Liquid. Dosages range from 250 milligrams to 450 milligrams daily. Lithium comes in both pill form and liquid form. And the dosages are also different depending on what you get. Other than lithium and antipsychotics, anticonvulsants are often used because they have the similar mood stabilizing qualities. These medications are primarily used for seizure prevention in individuals with seizure-related disorders, but they have been effective in treating bipolar. Occasionally, people with bipolar disorder may be prescribed anti-anxiety medication like benzodiazepines or selective serotonin reuptake inhibitors as an antidepressant. These medications aren't primary treatments, though. These medications are usually added on if necessary. So I apologize, guys. You actually have to be careful when prescribing antidepressants to individuals with bipolar disorder because it can induce a hypomanic or manic episode. Sometimes they can be safely used in conjunction with other medications, such as mood stabilizers, but it has to be closely monitored, and it's a person-by-person situation.
And some adverse effects and side effects to these medications, they range from minor tolerability, which can be fatigue and dry mouth, very unpleasant, to constipation and sexual dysfunction, painful to acute dystonia, which is a involuntarily convulsions of your muscles. From disfiguring, like weight gain, to life-threatening effects as well, such as myocarditis, which is the inflammation of the heart. And with drug-drug interactions, a lot of patients are prescribed more than one medication, which may include mood stabilizers, antidepressants, anticonvulsants, or antipsychotics. As Aaron just talked about, they can be safe to take, but some in combination depends on the effectiveness of them, and they can depend on the dosage. So symptoms and side effects are to be closely monitored by the patient and the prescribing physician to determine whether an increase or a decrease in dosage of medication is necessary. For example, if someone taking antidepressants with a mood stabilizer, if they're experiencing symptoms related to one or the other, that's when you would start consulting with your physician to see where the dosages range and where you stand basically with your symptoms to determine what needs to be done and what needs to be modified.
So some lab test requirements for lithium and antipsychotics. 5 necessary exams that you would use before taking lithium would be renal function, so looking at the kidney function of the individual, thyroid function. It's important that the thyroid gland is producing at a healthy rate because there's already a risk when taking lithium of there being an impact on the thyroid functioning. So it's just important to take that into account so that it doesn't impact it as a result of taking the medication. And that needs to be monitored every 6 months. An electrocardiogram, so this would look for heart problems and looking at the overall heart health of the individual. Full blood count, so looking at the blood levels, and this is really important because lithium already has a narrow therapeutic index, so that means that even just a small amount or a small difference in the dose or the blood concentration can potentially result in adverse reactions that could be fatal or lead to lifelong issues. So that would need to be monitored about every 2 to 3 months by a physician. And a pregnancy test is very important, especially because if the individual is pregnant, there's a possibility of the child having birth defects, and that can take place even just in the first trimester of the pregnancy. Also, administration during the final months of the pregnancy could result in the child having lithium toxicity. So if any of these exams aren't feasible, it's important that lithium's not provided for the individual, and they would use an alternative medication such as an antipsychotic or an convulsant. So when looking at the antipsychotics, there are exams that are more recommended. So to start off, you would look at the blood pressure and the weight of the individual. So this would be because the medication increases the risk for the individual having high blood pressure. And then with weight, the medicines often cause individuals to gain weight. So just to keep an eye on that throughout the process of the treatment. An electrocardiogram. This is mandatory in some countries, just depending on the antipsychotic. But it looks at the heart rate because there is such a high risk for heart issues when taking antipsychotics. And whenever the individual initially starts taking them, they would want to check to keep an eye on the heart health for about 1 to 2 weeks after starting the meds. And if the individual already has pre-existing issues, then they would want to be checked about every 6 months when on the medication. A full blood count. So this is just to see the overall health of the individual. Checking the urea and electrolyte levels. So this is baseline, just to get a baseline idea of their urea and electrolytes. But especially with the electrolytes, if there are any abnormalities that can increase the risk of heart problems. So just keeping an eye on that since there's already that risk when taking the medication. And then some other baseline tests like renal function, liver function, and blood glucose levels because there's a risk of diabetes when taking the meds, lipid patterns, and prolactin levels. So this will just give you an idea of the cholesterol levels, especially because the medication will put the individual at risk of having high cholesterol.
Some relevant issues with treatment of bipolar. Let's talk about pregnant and nursing women. Treatment is most effective if the pregnancy is planned, as extensive consultation with providers is recommended, due to depending on the trimester and things like that. Depends on the medication dosage, especially with the lithium, like Annie talked about. Lithium is one of those medications that is excreted through breast milk. So after the fact, the consumption of that by the baby could have some effects. With children and adolescents, a therapeutic relationship is essential for effective treatment. So it's obviously recommended that anybody with bipolar get medication treatment and counseling, but for children, it's most important as well. And when it does come to the medications used to treat kids, a common side effect is weight gain with them. And unfortunately, long-term safety data is unavailable with medications for bipolar, so symptoms should be closely monitored with children since they obviously begin taking it a little earlier or a lot earlier than some adults. And with elderly, the management of bipolar disorder may appear differently. The onset of bipolar after the age of 50 is usually around 10% or lower. So it's not very common that they get a diagnosis that late in life. So psychosocial treatments are sometimes focused on a lot due to the late diagnosis.
All right, so I found a double-blind placebo study that essentially tested the usage of lithium for the treatment of pediatric patients with bipolar 1. Essentially half the individuals who participated were given a placebo, the other half were given lithium. Patients underwent treatment for 8 weeks with either the placebo or the lithium, depending on which they got. And there were check-ins on week 1, 2, 3, 4, 6, and 8. And on the few weeks they didn't do a check-in, they called them by telephone. In order to be part of this, you had to cease using all medication. Anybody who had achieved stability on any other medication was disqualified because they didn't want them stopping a medication they had achieved stability on to do this. So those who ceased medication usage and they tested as not having anything in their system were able to proceed. They did some baseline testings using the YMRS assessment to determine how their symptoms were before they began treatment, and then they did follow-up testing using the same assessment. So they found in the conclusion, lithium exhibited efficacy in the acute treatment of pediatric bipolar 1. With the dosing regimen used, lithium was found to have a generally acceptable adverse effect profile. Although use of the sustained release formulation of lithium may aggravate vomiting, this question is empirical and has not yet been tested. So essentially it works well. It has minimal concerning side effects, except it does tend to cause vomiting sometimes. But they're trying to figure out exactly, what causes it and if it really is lithium. And if so, in most cases, is it worth it? Is it not? But it was effective in treating bipolar 1 in pediatric patients.
So for the research-based experiment, we looked at a systematic review and meta-analysis of clinical predictors of lithium response in bipolar disorder. So close to 4,000 trials and observational studies were looked at. Some specific factors that they took into consideration when looking at these trials is the course of illness, if there was a family history of bipolar disorder, a family history of a lithium response, the age at onset, the number of bipolar disorder hospitalizations, there is a mania depression interval course sequence, if there's a depression mania interval, continuous cycling, which is if there are less than 4 episodes per year without euthymic intervals, which is a normal mood, and rapid cycling, which would be more than 4 episodes per year without euthymic intervals. And then lastly, bipolar disorder. So after having all of these different factors to take into consideration, they eliminated the majority of the trials and ended up only looking at about 300 different trials and observational studies, specifically with adults that were diagnosed with bipolar disorder and receiving treatment with lithium monotherapy. So a lot of the results were really inconsistent, just because so many were being reviewed. For example, one of the studies found that late onset was typically associated with a good response to their treatment, but when looking at the overall results of the studies, there was not a display of an association. After looking at all of the different studies, they came to a consensus that 6 predictors had good responses with the lithium treatment. That's with the mania, depression, or depressive interval sequence, absence of rapid cycle, so less than 4 episodes per year, an absence of psychotic symptoms, shorter pre-lithium illness duration, family history of bipolar disorder, and later illness onset. So the meta-analysis recognized that many of the studies reviewed showed different areas of good responses for lithium treatment, but these studies aren't necessarily accurate and reliable due to certain factors such as not providing statistical data, there being small sample sizes, and one important one that they talked about pretty frequently was how they didn't look at the different predictors and how they impacted one another. So in the discussion section, they talked about the different limitations throughout the majority of the studies and concluded that the results are really unreliable and shouldn't necessarily be taken into consideration when looking at the effectiveness of lithium treatment. And that's mainly because there are multiple predictors in the effectiveness and how important it is for interactions to be looked at and how they like within the predictors, and because of the complexity of the medication and the symptoms that the individual is experiencing, and how that impacts the effectiveness of the treatment.
And here's
And these
our
are all.
references.